Dr. Adhikari, can you start the proceeding?
Um, First of all, I'd like to welcome you all for this session. And uh, I don't have the detail of the next presenter because nobody has provided it. So can I ask the first presenter to present his topic?
Okay, so I'm Dr. Ibrahim Oman from India. So the first topic would be uh, uh, Eisenmenger syndrome in the current era by Dr. Arun Gopalakrishnan from Srijita Institute, Trivandrum. He's a well-known pediatric cardiologist and and recently published a statement article on pulmonary hypertension. Over to you, Dr. Arun.
Thank you, sir. Good evening to all, one and all. And I'll be briefly discussing on Eisenmenger syndrome in the current era. So Eisenmenger syndrome is one of the longest standing definitions in cardiology till date. It refers to reversal of a left to right shunt to a right to left direction or a bidirectional shunt due to progressive pulmonary vascular disease. And this is an old definition which was initially proposed by Victor Eisenmenger in 1897, and then it was made immortal by Paul Wood's series in 1958 in British Medical Journal, where he used the definition of a pulmonary vascular resistance of more than 10 Wood units to as the human definition of this condition. The classical epidemiology, as we all know, is that it constitutes around 3 to 7% of all congenital heart disease patients. Virtually all survivors of unrepaired large post-tricuspid shunts can end up in Eisenmenger reaction if they survive, and 6 to 10% of unrepaired large pre-tricuspid shunt lesions can develop Eisenmenger syndrome. And there is also a subset of unrepaired cyanotic heart disease, which fall into transposition physiology, where while 90% do not survive infancy, all who survive end up with Eisenmenger syndrome, and also variable incidence in those with admixture complex congenital heart disease as well. But there has been a change in the epidemiology of Eisenmenger syndrome, which is why we are discussing it today. Paul Wood in his initial series described 18% prevalence in congenital heart disease cohort, and AV canal defects was the most common in his series. Now, the Euroheart survey in 2005 identified an incidence of 5.7, the prevalence of 5.7% in all congenital heart diseases. The Netherlands group from the Concord registry, they have identified a 1% prevalence in all congenital heart defects. And Belgium came up with population-based data where they identified the prevalence of Eisenmenger syndrome in the general population to be 11 per million inhabitants, and half of them were Down syndrome. So this reflects the improvement which has happened over the years in the treatment of this condition. Now, there is also relevance in the changing epidemiology of Eisenmenger syndrome, which is reflected in the 2025 ACC AHA guidelines for management of adults with congenital heart disease, where besides Eisenmenger syndrome, as we all know, there are other 3 subsets which are of importance. That is prevalent systemic to pulmonary shunts with elevated PVR, yet not meeting the criteria for Eisenmenger syndrome, coincidental defects with elevated pulmonary vascular resistance, and post-correction defects with elevated pulmonary vascular resistance, which all need careful evaluation pretty much along the same way as Eisenmenger syndrome. Now, what has happened over the period of time over the past several decades regarding the diagnosis? ASD, the age of diagnosis of Eisenmenger syndrome is pretty much remained the same with pre-tricuspid and post-tricuspid shunts. There has not been much change over the years in the age of diagnosis. But then what is the change that has happened? We've had more survivors with Eisenmenger syndrome and less new ones. But what do they survive with? They survive with several issues which are multidisciplinary. They involve pulmonary issues. There are cardiac failure, pericardial effusion, arrhythmia as they survive. And there are multisystemic involvement like GI effects with gallstones and cholecystitis, musculoskeletal issues, stroke and cerebral abscess, endocrine issues, renal issues related to alterations in the GFR, secondary erythrocytosis and bleeding and thrombotic issues, and then, of course, the issues related to long-standing cyanosis. Now, has there been a change in the cause of death in Eisenmenger syndrome in the modern era? And the answer to that is yes. Quoted two papers here, one in 2017 by Kirchhoff et al. And they've identified heart failure to be 34% as the cause of death. In the olden era, the incidence of bleeding and periprocedural complications being as a cause of death used to be more common. That has come down significantly over the past 3 decades. And now hemorrhage has come down significantly, and which used to be a very common cause in the past. Now, while the European series identifies hemorrhage in 7%, the Indian series, which was published from our center, we've noted hemoptysis in 16% of deaths due to Eisenmenger syndrome. But heart failure remains the most common cause of death in Eisenmenger syndrome in the modern era, unlike bleeding, which was the more common one in the past. The incidence and to note is that pneumonia, which we think does not happen once the pulmonary vascular resistance sets in, is established, actually constitutes a significant proportion of deaths in older patients. So that is another cropping up cause of death in Eisenmenger syndrome. So what has happened to the survival rates of Eisenmenger syndrome? That is the area where there has been significant change. In Portwood series, most of the people used to die in the 3rd decade, but current data shows, like the data from Saha et al. In 1994, the 5-year, 10-year, and 15-year survival were 86, 79, and 76% with Eisenmenger syndrome. Now, Eisenmenger syndrome, although fits into group 1 pulmonary hypertension, the survival rate is much better than that of idiopathic pulmonary hypertension. So that is the reason we should be very careful. I mean, we should not rush all these patients into more advanced invasive strategies, but there are so many other things that we can do before to stabilize them. And the median survival is now 52 years, which is much better than in the past. In our series, the mean age at death in complex cyanotic heart disease, Eisenmenger syndrome, was 17 years. In post-tricuspid shunts, it is 33 years. And in pre-tricuspid shunts, the mortal age at death was 42 years. So there are people who are surviving into the 6th decade and beyond. So when we try measures for risk stratification, the tools used are pretty much similar to what is used for other forms of pulmonary hypertension, specifically the idiopathic group 1 pulmonary hypertension. The REVEAL PH risk score, which uses the cardiac catheterization data. The REVEAL Light 2 risk calculator, which skips the cardiac cath data, but is more useful in the OPD setting. And the ESC-ERS3 strata model are routinely used in a pulmonary hypertension clinic to risk stratify them at diagnosis. And on follow-up, the European Compara scale is used to risk stratify the patients into low risk, intermediate low risk, intermediate high risk, and into high risk. And the same categorization can be used as IPAH. Now, what are the adverse prognostic indicators in Eisenmenger syndrome? Those who have reduced exercise tolerance. A 6-minute walk distance is a simple tool that can be used, and there are various cutoffs which say 350 and 400 being the thresholds of where the curves tend to diverge. Low resting oxygen saturation, advanced NYHA class, moderate to severe lung function impairment, reduced diffusion lung capacity, low peak oxygen consumption, elevated proBNP more than 500, elevated CRP levels, thrombocytopenia below 1 lakh per liter, low transferrin saturation, and established RV dysfunction. These are the adverse prognostic indicators in Eisenmenger syndrome. And we've in our study, we've identified resting saturation, oxygen saturation of less than 80%, had a 95% sensitivity and 65% specificity for mortality in Eisenmenger syndrome. And the presence of atrial arrhythmias and absence of targeted PAH therapy were also identified as predictors of mortality. Now, the Michael Gatsoulis group came up with this this tabular format of risk stratifying patients and identifying the risk for mortality, which takes into account the type of shunt, whether it's pre-tricuspid or post-tricuspid, the presence or absence of pericardial effusion, and the 6-minute walk distance and the oxygen saturation at rest. And this can be a tool that can be used for counseling. Now, what has changed in the management of Eisenmenger syndrome is the advent of targeted pH-specific therapies, which was initially started for IPAH. Now, there is upcoming data in most of the classes of pH therapies. Initial data was on endothelin receptor antagonists, and bosentan was the first to be used widely, thanks to the BREATHE trial. And then Maestro trial gave some data regarding macitentan's use. There is no discrepancy in the recommendation by the European and the American societies regarding the use of ERAs in Eisenmenger syndrome. It is a class 1 uniformly. Now, when you come to phosphodiesterase inhibitors, 5 inhibitors, ACC considers this as a class 1 medication for Eisenmenger syndrome, while ESC gives it a class 2A recommendation. There is no specific recommendation by the ACC/AHA for risegoude use in Eisenmenger syndrome, while ESC permits a class 2A recommendation based on the patent 1 and 2 trials. The prostacyclin analogs and receptor agonists still only the inhaled, the iloprost and the inhaled medications reflect in the ACC and ESC guidelines, although selexipag is an emerging drug which is being used quite often in Eisenmenger syndrome. The activin signaling inhibitors are yet to find a recommendation in either the European or the American guidelines. Now, is it beneficial? Is it useful to give targeted pH therapy for these Eisenmenger patients? Now, there are a few trials that have specifically looked at that. Though it's noted that those who have got advanced grades of symptoms then tend to have a better hemodynamic response. And this is a trial which is published in the Journal of Heart and Lung Transplantation 2017, which specifically looked at cath data. And they noted that there was an initial fall in pulmonary vascular resistance index and change in transpulmonary gradient and improvement in QP and 6-minute walk distance with the pH specific therapies. They considered both escalation of therapy and initiation of new or initiation of dual, all were considered. And the response tended to plateau over a period of time. Now, our study from Chitra, we've identified that although ours was a retrospective study, we identified that those who had received targeted pH therapy had survival benefit on follow-up, and those who had post-tricuspid shunts tended to do better than those who had pre-tricuspid shunts. And however, the pre-tricuspid and Eisenmenger syndrome patients tended to have a better response to pH therapy than post-tricuspid and Eisenmenger syndrome with respect to symptomatic improvement and 6-minute walk distance. Now, coming to the disease-modifying therapy, that is activin signaling inhibitor, that is sotatercept. There is no data, as already mentioned, regarding for the formal recommendation of this therapy in Eisenmenger syndrome. And there is a study, the SUMIL study from Japan, Kyushu University, and the trial is ongoing. But till date, there are several case reports which show that there is symptomatic improvement. And of course, the mechanism of action is similar to in IPAH. The activin signaling pathway is affected by interfering with the pro-proliferative and anti-proliferative pathways. And there is also at the same time one case report which was published earlier this year of a patient who developed pericardial tamponade 84 days after initiation of sotatercept, and there were no other identifiable causes. And there is also a report of sotatercept-related pericardial tamponade in other patients other than in Eisenmenger syndrome. So we are still awaiting formal data on this account. Now, is it only pulmonary hypertension that is the issue, or does pulmonary artery dilatation also cause an issue? Yes, pulmonary artery dilatation per se can also cause an issue, but other than the pressures in the PVR, it can, and it is defined as severe dilated when it's more than 50 millimeter in adults. It can lead on to compression of the left main coronary artery, myocardial ischemia, recurrent laryngeal nerve compression. We've also seen patients who come with dysphonia and dysphagia, and the Otner syndrome is described in Eisenmenger syndrome. It can also lead on to pulmonary artery in situ thrombosis and pulmonary artery calcification. Now, one of the dreaded complications in Eisenmenger syndrome is hemoptysis, and that has remained a concern throughout the past. And what causes bleeding? Where does the bleeding come from? It's mostly from the bronchial arteries, rarely from the pulmonary arteries. What causes this hemoptysis? It is the dilated bronchial arteries which rupture with the shear stress. And hypoxemia and related neovascularization is often the site where it gets ruptured. And pulmonary in situ thrombosis can also be contribute to hemoptysis. And there are several coagulation and platelet-related abnormalities which are known in Eisenmenger syndrome. But at the same time, we should note that hemoptysis as a cause of death has come down over the years, as already mentioned. So how do we manage these patients with hemoptysis? That is why we have been able to reduce the mortality. Now we know that we should keep the patient in position such that the bleeding tongue is placed in a dependent position. And if the patient comes in with respiratory distress and intubation is required, we consider selective intubation or the use of double lumen tubes to safeguard the normal lung. And then bronchoscopy and or a CT pulmonary angiography is done to identify the bleeder. And in the meantime, patients are considered for blood products and reversal of anticoagulation the patient is already taking. Regarding the use of tranexamic acid, can be used cautiously because it has a prothrombotic effect as well. And then now there's emerging data that we do CTs, and then if you identify a bleeder, we coil embolize the bleeders. That can also lead on to reduction in hemoptysis. Besides these problems, what are the other issues with lung function abnormalities? These are the things that are newly identified. There is reduced predicted forced vital capacity, and the FEV1 by FVC is identified to be less than 70%, one-third of stable Eisenmenger syndrome, which was not identified in the past. So there is decrease in the peak oxygen consumption, elevated ventilator efficiency to carbon dioxide VCO2 slopes, reflecting inefficient ventilation, increase in dead space. These are the reasons why pneumonia and LRTI is emerging as a major cause of death in Eisenmenger syndrome, which we thought was rare in the past. Now, does that mean that we can use oxygen as a therapy? Well, long-term oxygen therapy in Eisenmenger syndrome is still an uncertain area. Of course, there are situations where it is required, because several of these patients have nocturnal hypoventilation and sleep-related breathing disorders. And obstructive and central sleep apnea is reported in 70% of adults with Eisenmenger syndrome. Is there a role for vaccination? Yes, influenza, pneumococcal, and other vaccines as per the epidemiology. Now, some of these patients who survive longer, they come up with other issues which we have never thought in the past. They include the role of air travel. Now, can the patients travel? Yes, there were concerns raised in the past, but now we've identified that the shifts in oxygen hemoglobin dissociation curve tend to attenuate the effects of low oxygen tension during air travel, and most Eisenmenger syndrome patients can fly safely without hassles. The ventilation perfusion mismatches and emission limitation can, of course, worsen at high altitude. However, the right left shunting does not increase. That is identified. And what care needs to be taken? These patients should be well hydrated and they should be allowed to move around. And supplement in-flight oxygen can be permitted for those who have resting saturation below 80%. And we are all aware of anemia as a cause of events in Eisenmenger syndrome. There is a concept of relative anemia, and hemoglobin less than 14 gram per deciliter is to be considered anemia in these patients, and that they affect the prognosis. We can treat them with iron, but everyone should note that routine phlebotomies are contraindicated in Eisenmenger syndrome, should be considered only for those with high viscosity syndrome. Another area of concern is how can these patients undergo non-cardiac surgery? Unplanned anesthesia is associated with adverse events in Eisenmenger syndrome. Avoid intubation wherever possible, and as post-pressure ventilation worsens RV function. Consider low tidal volume and low PEEP, and local anesthesia and neuroaxial blocks are preferable to GA. Now, pregnancy in Eisenmenger syndrome, historically, of course, it's considered a contraindication because heart failure worsening in second and third trimester and early postpartum. High maternal mortality rates in IUGR, but what does the data show of late? Now, The latest data shows that, of course, there is varying incidence of maternal mortality, but recent data shows that among compared to IPH, Eisenmenger syndrome can be managed with the careful monitoring in pregnancy heart team approach. The maternal mortality rates tend to vary from place to place, but there is some scope for careful management. And now, if the patient does get pregnant, and they are and we advise termination, but they are still hell-bent on continuing. How do we go forward? Eisenmenger syndrome, there is no definite advantage of C-section over vaginal delivery, unlike IPH, because acute RV dysfunction is less likely with large post-cycle shunts, and acute volume shifts are better tolerated with the help of LV. Of course, there is a concern that fetal losses may also be more with cesarean section. And we have to be careful regarding anesthesia management. Epidural anesthesia, continuous spinal catheter is preferable. Careful use of GA, and be careful with oxytocin. Arrhythmias are another issue in patients who survive longer. SVT is more common than VT, and these patients need rapid restoration of sinus rhythm. And subcutaneous ICD may be a concern for those, may be a consideration for those who need an ICD. Now, coming to transplant, where do we go? What are the options for end-stage symptomatic Eisenmenger syndrome? We have to consider between bilateral lung transplant versus heart lung transplant. These are the list of indications for transplantation, and what are the outcomes. There's not much difference. There's contrasting data from several centers, but in general, there's not much difference between bilateral lung transplant versus heart lung transplant. This is data from Papworth and from the Nordic group, which suggests reasonable survival with that 1, 5, and 10 years. The median survival after heart lung transplantation in Eisenmenger syndrome is 12 years from the Nordic data. At the same time, there is some information regarding the choice of therapy. Heart lung transplantation is preferable for those with VSD Eisenmenger, but bilateral lung transplant with cardiac defect repair may be preferable for ASD Eisenmenger syndrome based on some of the recent published data. And at the same time, we should note that post-transplant survival is lower for Eisenmenger syndrome than IPH. So should be careful, think twice before referring these patients for transplant, because we can manage them otherwise. Lymphatic dysfunction is another newly identified issue. It's often underappreciated. They are often managed similar to other lymphatic dysfunction, like with the dietary modification medications and target lymphatic interventions. Exercise rehabilitation. Exercise used to be a contraindication in the past, but now exercise is encouraged in Eisenmenger syndrome. And exercise rehabilitation at the same time has to be individualized according to cardiac anatomy, ventricular function, arrhythmia history, and exercise response. So to conclude, Eisenmenger syndrome has improved survival in the modern era. It is definitely much better than PAH. At the same time, transplant survival of Eisenmenger syndrome is worse than IPH. Multidisciplinary approach is required, as the Eisenmenger syndrome in the modern era has much better survival than in the past, and the issues are multidisciplinary. So we need a holistic approach and a patient-centric approach with a shared decision making. Thank you.
Thank you very much, Dr. Adhikari. Can you introduce the next speaker?
Yeah, I'm sorry, I'm out of my station right
Okay,
now.
I understood.
Can you do that
So
for
I
next?
would do that. I would do that. Or okay, this is invite Dr. Feigow for management of pulmonary hypertension and heart failure. Over to you, doctor.
Thank you, Chairman. It's my great honor to attend this meeting. Wait a moment, let me share my slides. Okay, could you see my slides?
Yeah, we can
Yes.
see right now.
Use your slides,
Thank you.
please.
Hi, good afternoon, everyone. I'm Dr. Gao from Anjin Hospital. It's my great honor to meet you here and to give the presentation about the management of hypertension in patients with heart failure.
Sorry, excuse me. 高教授，您能放一下这个播放模式吗？谢谢。OK。
So pulmonary hypertension is not an uncommon situation, and it serves as a fatal complication in patients with heart failure. For a long time, the condition has been left untreated or under diagnosed due to its complex phenotypes of the lesion of the patient. So first, let's clarify the classification of pulmonary hypertension and complicated with heart failure. And according to the latest guidelines, pulmonary hypertension secondary to life heart disease is defined as group 2 pulmonary hypertension, and it's account for the majority of all all cases of pulmonary hypertension. Over 80% of all patients were group 2 pulmonary hypertension. Well, this figure shows the prevalence of pulmonary hypertension, and it's actually remarkable for patients with heart failure. And overall, it occurs in about 40 to 60% of patients with chronic heart failure. And when we stratify the heart failure by substep, pH affects about 60 to 80% of patients with HFpEF and about 40 to 70% of patients with HFpEF. So the long-term follow-up study indicate the elevated mean pulmonary pressure is an independent predictor for mortality for patients with heart failure. And it indicate management of pulmonary hypertension is key for improvement of patients with the management of heart failure. So here the table shows the universal hemodynamic criteria for pulmonary hypertension, and according to the guidelines, mean pulmonary pressure more than 20 millimeter mercury is defined as pulmonary hypertension. So what's the mechanism linking heart failure to pulmonary hypertension? And the core hemodynamic feature is clear. During heart failure, left arterial pressure was increased, and this increased pressure transmit retrospectively through pulmonary veins to capillary, and this caused passive pulmonary congestion. And during chronic increased elevation of capillary pressure will generate pulmonary endothelin dysfunction. It causes downregulation of vasodilators and overproduction of vasoconstrictors, and that would include pulmonary vasoconstriction. And continuous vasoconstriction will lead to smooth vessel proliferation and pulmonary vascular remodeling. So in the end, the elevated pulmonary resistance caused by remodeling will lead to right heart failure, increase the right ventricular offload, and eventually cause severe right heart failure. So therefore, the passive elevation of left atrial pressure is the key to differentiate the group 2 hypertension to other types of hypertension. So for group, such as for this group 1, 3, and 4, 5, the hypertension, the initial trigger of hypertension is caused by a pulmonary remodeling and elevated pulmonary vessel resistance, and that's cause increase of right heart afterload and reduce right heart failure. But in group 2 hypertension, the initial trigger is because the passive transmission of the pressure of left atrium. Well, and let's see, there are two hemodynamic phenotypes within pulmonary hypertension related left heart disease, which is isolated pulmonary isolate post-capillary pH, often referred as IPC pH, or combined capillary pH, or CPC pH. And the threshold to differentiate the two phenotype is use PVR, about 2 Woods. So for patients with IPC pH, it's largely driven by passive backward transmission of the left atrium pressure, and it's most common subtype of PH-LHD. But for if the PVR is more than 2 Woods, it indicates the patient developed CPCPH, and it also caused by a concomitant pulmonary vessel remodeling, and the patient usually have severe long-term prognosis. Well, and for the clinical manifestations of heart failure related to PH, there are also 2 distinct clinical phenotypes between HFrEF and HFpEF. For those patients with HFrEF related to PH, disease originates from severe left ventricular dysfunction, so mostly present as the IPCPH with low PVR. And the management of those patients mainly focus on improving systolic function and restrict volume control. But in contrast, for those with HFpEF related PH, the disease normally starts from isolated diastolic dysfunction and passive conjunction. But as the time goes by, it will increase in at the late advanced stage. The disease will progress to CPCPH quite often, and those patients normally the hemodynamic features is similar to idiopathic PH, so it leading to higher chance of misdiagnosis. So the precise diagnosis of the patients with heart failure related to PH faces weird clinical challenges due to its clinical heterogeneity, and there are some overlapping comorbidities for the patient. So a standard diagnostic algorithm should be include a comprehensive medical history and a screening for PH by echocardiogram. But when the result of echocardiogram and clinical findings are inconsistent, right heart cath is mandatory in this situation. But in some ambiguous cases, provocative tests, including excess right heart cath or rapid saline infusion, should be considered to unmask those latent elevated PAWP. So let's move on to the therapeutic strategy for the patient with heart failure related to pulmonary hypertension. Well, currently there are no specific approved drugs for patients with PH-LHD, and routinely use of PAH agents, targeted agents, are not recommended according to the guideline. Those fundamental rules of management of this patient is to treating their underlying diseases and to improve their left heart function. So the first line standard heart failure therapy should be prescribed to all of the patients. Currently, there are some clinical studies indicate most current PAH agents failed to show clinical benefits in those patients with group 2 hypertension, because it's largely driven by safety reasons, such as those endothelin receptor antagonists. Those agents can cause fluid retention and worse heart failure. And prostacyclins normally would improve hemodynamic features, but it may not reduce mortality. Nowadays, there are some of the novel agents under investigation to treat this group 2 hypertension. Currently, the sotatercept is like a rock star for treatment of pulmonary hypertension, and it can inhibit the actin pathway and to reverse pulmonary remodeling. Currently, the medication is approved by FDA and SFDA for the group 1 patients with PAH. But however, this year, the condensed study was published a circulation to enroll patients with HFpEF with CPC-PH, and the result also showed remarkable improvements for those hemodynamic features as well as clinical symptoms for patients with group 2 hypertension. Another promising agents in this patient is relaxing analytes. This is agent with dual effect with both anti-fibrosis and anti-inflammation. In some early stage study, it showed improvement of hemodynamic features, reduced PVR, but currently there are no large data to support the use of this agent. There are phase 2 study is ongoing. Well, here shows a series of potential agents on the pipeline, but all of them are in early stage of clinical study. But this shows the trends that currently this research the shift from simply vasodilation to multi-targeted interventions, including vascular remodeling and metabolism and improved cardiac function. So in recent years, there are some breakthroughs in the devices-based therapy for patients with group 2 hypertension. For example, pulmonary artery denervation created by Chinese doctor, Professor Chen. And I think Professor Zhang will go through the details of these devices. So I just want to emphasize this devices is a catheter-based ablation to denervate pulmonary sympathetic nerve, and it can improve PVR and pulmonary pressure. And there is a remarkable study published, I think a remarkable study named PANDA-5. The study enrolled patients with heart failure-related hypertension, and we showed a promising clinical result. And the result was consistent throughout 3 years of clinical follow-up. So there another interesting device related to therapy is a shunt device. The core logic of this device is to create a left-to-right arterial shunt to decrease the elevated pressure and relieve pulmonary congestion. The small early studies show promising results, but large randomized clinical results shows inconsistent results for patients with group 2 hypertension. So lastly, there is another, I think it's very interesting devices. It's called Pulmonary Artery Compliance System. The design of the system is similar to IABP in left heart. It was an inflated balloon device implanted in the main pulmonary artery to boost the artery compliance and reduce RV afterload. So the early study shows improvement on hemodynamic features such as improved RV and pulmonary coupling and improve PVR. So in summary, currently there are extremely high heterogeneity of the clinical phenotype of patients with heart failure related to pulmonary hypertension. And the current study for treatment of those patients were limited with small sample size and short follow-up studies. So we should remember hemodynamic improvements does not always translate to clinical benefits. So further validation of those novel agents and interventional devices in large randomized clinical trials is warranted in the future. So thank you for your attention.
Thank you, Professor. That was a wonderful talk. I invite my co-moderators, Ying Liu, to introduce the next speaker.
Thank you very much. It's my pleasure to introduce Dr. Ramanatha Collegood from the National University Heart Center in Singapore. Dr. Ramanatha Collegood is the Director SEO Fellowship Program NUH Singapore, research the Director Department of the CTVS NUH, and Associate Professor, National University of the Singapore, and is the Chair Publication Committee Extracorporeal Life Support Organization USA, and the past Chair Scientific Organizing Committee ELSO, and the topic the 2% most cited scientist worldwide. It's a famous professor. The third topic is right in right heart failure. Please welcome Collegood. Please.
Thank you. Thank you, Professor Yu. Good evening, good afternoon to everyone. I'm a cardiac intensivist at work, so I probably would be bringing in a different perspective to the failing RV because as an intensivist, I get to see some of the acute right heart failure being managed intensively in my unit. I've just zoomed out of the topic that was given to me, which was specific about R-wire. I've chosen to talk on mechanical cardiac support for the failing RV. At the outset, not much conflicts to declare, except that, I'm the chair of publications at ELSO. So a lot of my talk might revolve around ECMO, and clearly, that's one of those devices used in right heart failure. But having said that, before we talk about how mechanical cardiac support devices work in right heart failure, let's take a step back. And let's take a step back and think how the right ventricle functions. In fact, if you look at right ventricle per se, you would all agree with the fact that soon after birth, when left ventricle takes over the systemic body function, the right ventricle becomes the forgotten ventricle. I'm not trying to be philosophical or emotional here, but that just puts a big question mark on a lot of things. And many of the gray areas surrounding the diagnosis of right ventricular dysfunction, as well as the management of right ventricular dysfunction, to me, it pertains to this big, I would think, domain about the forgotten ventricle. Now, why is the ventricle forgotten? I mean, we all know from an anatomical perspective, the right ventricle and left ventricle are totally different. Clearly, in terms of coronary blood flow, as well as the muscle mass, the right ventricle is definitely different from the left ventricle in many ways. And as I said earlier, right ventricle is the systemic ventricle during gestation. And as soon as we take our first breath, we transition to a postnatal physiology, leading to a reduced importance of right ventricle, which essentially becomes a passive conduit, while the left ventricle takes the predominant function. Now, let me bring an analogy here to explain this better. On any day, I would compare the left ventricle to a donut. It's sweet, it's attractive, and clearly, it gives you more calories than any other thing. However, the right ventricle, to me, I mean, this is more an analogy from a morning breakfast perspective, but still, I would think it holds good to understand the totally different perspectives between the ventricles. The right ventricle looks like a French croissant. So essentially, it fits into that space. It's awkwardly shaped, and it gives you a savory taste. The amount of calories probably less than what you would get from a donut. And that's exactly what happens when the heart starts pumping too. Now, let's extend this analogy. I'm going to stretch this analogy to that patient who has right heart dysfunction. Now, in a patient with right heart dysfunction, we all know the RV gets dilated, the septum gets flattened. And going back to the analogy of the donut, essentially, the left ventricle now represents a half-eaten donut. So you're not going to get much calories, and at the same time, it's very much compressed. While the right ventricle is no longer a French croissant, it essentially looks like a Danish pastry. So clearly, swollen in size, and that's essentially, the best way you understand the concept when a failing heart is there in front of you. Now, for those who believe in physiology, because these are concepts which are tough to understand, the right ventricle and the left ventricle are best understood in heart failure by understanding their pressure volume loops. Now, just as these are the normal pressure volume loops that has been put up here. Just as the left ventricle has a rectangular pressure volume loop, which reflects its pump function, the right ventricle also has a pressure volume loop. Mind you, the right ventricular pressure volume loop is more or less trapezoidal. And clearly, it's much different from what the left ventricular pressure volume loop is. Now, I'll come to this later when we talk about mechanical cardiac support devices used in right heart dysfunction. And I think that might make these pressure volumes loops more distinct in terms of how you understand heart failure and how we manage it. Now, again, as an intensivist, I get to see right heart failure in different scenarios. Some of the common indications that I get to see where the patient's right heart fails, if it's an isolated right heart failure from a cardiac cause, it's usually secondary to right ventricular MI. I'm just quoting only the adult cohort here. Clearly, there are a lot of pediatric causes of right heart failure from congenital heart disease, as some of the previous speakers spoke about. The other group where the RV fails, and I get to see that in my ICU patients, is post-cardiopulmonary bypass after they've had a CABG. And last but not the least, I also get to see them in patients who have had a VAD implanted or post-transplant. Now, this is from a pure cardiac perspective. If you look at those patients where the lungs are infected or the lungs are chronically bad, two subset of patients, especially those with ARDS who need high ventilatory support, and those with severe chronic pulmonary would also present with right heart failure. And as an acute presentation, as a mix of both lung as well as cardiac pathology, we also get to see patients with pulmonary embolism. So clearly, it's a big spectrum of disease where the cause of right heart failure can be purely the lung, can be just the heart, or can be a combination of both. So with this kind of etiology in the back of your mind, I'll now take you through to how we assess right heart failure or right heart dysfunction in critically ill patients or acutely presenting patients. Now, most of these parameters are echo-based, and there are many of them which are currently being used. One of the popular ones is the pulmonary artery pulsatility index. I'll talk about it when I talk about MCS devices and the decision to go on MCS devices comes. But having said that, CAT or echo-based assessment is critical to assessing the right heart dysfunction. Now, as part of management of any acute heart failure, our first line management in this context is always inotropes. Clearly, whether it's right, left, we use the same kind of inotropes to get it going. However, there's a small difference here. We also need to know that when patients are having right heart failure and they are on inotropes or pressors, you would get to see that as the dose of inotropes or pressors increase, their mortality increases. So a classic example would be a moderate dose of single inotrope, and this patient in that dynamic process of cardiogenic shock eventually ends up having 2 or more inotropes on board. You'd see that the mortality jumps by 6 to 7%, so 6 to 7 times. So going on to say that too many vasopressors are equally bad. However, in the context of right heart dysfunction acutely, there are other medical management that we also attempt. In addition to inotropes and pressors, we do use systemic pulmonary vasodilators. We do correct the underlying cause. Say if it is pulmonary embolism, we give them thrombolytic therapy. We do inhalational agents. So nitric oxide is the classic example where these patients are acutely managed when they have right heart dysfunction. Now, when all these medical therapy fails, or when right heart failure is refractory to the standard medical management, you then go in search of MCS devices that would be apt for right heart dysfunction. Now, if I were to broadly classify these MCS devices, I would call them, or I would classify them by virtue of how they achieve unloading of the right ventricle. So devices such as the impeller right side, the tandem heart or the protect duo, which is essentially a modification of ECMO, are all direct RV bypass devices. While in devices such as VA ECMO and up to a certain extent IABP2 are indirect RV bypass devices. So the mechanism by which these devices work it's entirely different. So impeller would work with an axial pump, while the rest of the devices would work with a centrifugal pump. Now, let's talk about it more. So in terms of mechanical cardiac support devices for that failing right heart, what are my options? As I presented in my previous slide, I have a series of options, of which I would like to go into the ECMO options first. Now, in terms of ECMO options first, I have still options on how I configure my ECMO circuit depending upon the etiology of right heart dysfunction. So if the etiology of right heart dysfunction is predominantly respiratory, then removing the hypoxemic effect or the gas exchange effect on the right heart might improve right heart function. And that's where veno-venous ECMO is predominantly used. The rest of the ECMO devices are essentially to support right heart dysfunction in the context of cardiopulmonary dysfunction or cardiac dysfunction per se. So veno-arterial ECMO or venopulmonary ECMO or veno-arteriovenous ECMO are all used in that context. How does a veno-venous ECMO work? So to be very, to simplify this to the core, a veno-venous ECMO essentially means there are big size cannulas placed in your femoral veins and your jugular vein. Blood is taken out of your femoral vein, sent to the centrifugal pump, which is the artificial heart, then to an oxygenator, which is an artificial lung, and blood is pumped back into the jugular vein, that is to the right side of the heart again. So essentially, it doesn't unload the right ventricle in a big way. However, it corrects the oxygenation deficit, it corrects the gas exchange deficit, and thereby improves some element of right heart dysfunction. This is classic in those patients with severe respiratory failure who have concomitant right heart dysfunction. Now, coming to those who have cardiopulmonary failure, where right heart dysfunction coexists with cardiac failure, or those with just cardiac causes of right heart dysfunction, your support is going to be predominantly circulatory. So in this configuration of veno-arterial ECMO. You would take blood out of the venous side through huge cannulas from the femoral vein, send it through the centrifugal pump oxygenator, and the oxygenated blood is now pumped into the arterial side through the femoral artery. So clearly, by this process, blood is sucked out of the right ventricle. So there is active unloading of the right ventricle, and blood goes back to the left ventricle. So essentially, blood is actually pushed not to the left ventricle, to the left side of the circulation. Now, in this process, one thing that we all tend to face as we manage these patients with cardiac dysfunction, especially in the context of using veno-arterial ECMO, is the return blood flow is against a beating left ventricle. So essentially, it questions the physiology of left ventricle. It tries to load the left ventricle in a big way. This leads essentially to a big clinical conundrum where you would find that though the end-organ perfusion is adequately attained, this configuration essentially loads a vulnerable ventricle, especially if the left heart is affected too. And in such context, you might end up unloading the left ventricle using unloading devices. And this essentially leads to support of both ventricles in one way or the other. But having said that, the broad take-home message, at least from an ECMO perspective, a veno-arterial ECMO perspective, should be that these are devices that unload RV right ventricle actively. This was one of the papers we published early this year, looking at extracorporeal life support in post-cardiotomy acute right ventricular failure. In fact, this was a multi-center retrospective study where a lot of centers contributed data over a period of 20 years from about 16 countries. And we looked at about 2,000 adult patients post-cardiotomy who developed acute right ventricular failure. And the good thing about this kind of extracorporeal life support in such specific niche indications is the fact that most of the time the in-hospital survival is more or less comparable with other cohorts of patients who have cardiac failure and need ECMO. So clearly, we showed that patients with a right heart dysfunction need longer support. However, the eventual outcome matches well with ECMO for other indications in the post-cardiotomy cohort. There are modifications of veno-arterial ECMO which would be needed, which we call as hybrid ECMO, and that has specific effects on the right heart, as well as we try to offload it. I'm not going to the details of it. The most important bit, which now is getting more and more popular in the management of right heart dysfunction, is the modification of the veno-venous ECMO circuit, whereby a cannula is inserted either through the jugular vein or from the femoral vein, and it goes and bypasses the right ventricle. So blood is sucked into this cannula from the right atrium and is given back into the pulmonary arteries, which essentially means that the centrifugal pump functions only to push the blood into the pulmonary artery, and this essentially gives right heart enough rest till it recovers. Again, this becomes important. A lot of modifications of these devices is currently being used in many ICUs. You'd find that you can use these devices even without the artificial lung, the oxygenator in situ. So clearly, such RVAD devices without oxygenators can be used long-term to support the right heart till they recover. Now, having said that, how are the outcomes with such modification of this cannulation? This was a paper which was published 2 months back, and they looked at exactly this configuration, and their findings essentially were that these patients required a venopulmonary ECLS predominantly for heart failure, and their 60-day survival was up to about 50%. So going on to say that, this is again one of those configurations used in the management of right heart dysfunction. The new kid in the block, Impella. Clearly, a lot of we get to hear a lot about this device, which was originally designed from the Archimedes screw pump, mainly, from the Middle East, where it's used for raising the water up, and the principle is essentially used in this particular device when it's used in cardiogenic shock. It essentially uses an axial pump. It's quite good in that. When it's used for the left side of the heart, it's physiological. However, the newer versions of these Impella devices are available, whereby these devices can also be used for right heart dysfunction. So the Impella RP is an FDA-approved device which exclusively gets used in right heart dysfunction. The configuration is quite similar to what I said with the specialized circuit in ECMO, except that this uses an axial pump. And you would find that these devices are increasingly being used in the management of right heart dysfunction in a lot of ICUs nowadays. Clearly, one of the important challenges that you face when you use such device is the position of the device. It tends to slip out, so you need to be clear, or units that use these devices have clear-cut protocols on making sure that such devices are held in position, especially, and their positions are verified during daily ward rounds. Again, these are criteria that are slowly being developed in the process of, or in as and when we use more Impella RP heart pump. Clearly, it's indicated in right heart failure. Some of the hemodynamic parameters and clinical parameters that would favor use of Impella RP are highlighted here, and the use is essentially augmented or enhanced by looking at a pulmonary artery pulsatility index. An index of less than 1 is a very good indication for the use of such devices. If you look at evidence-based, we are just building it up. Clearly, it's, as I said, it's the only FDA-approved percutaneous device in right heart failure. We clearly don't have other technology which has submitted outcome data in this population. But at least from the Impella RP Recover Right trial and the preliminary results, we get to know that that this device is safe, feasible, and outcomes are quite good. But those are small numbers. Last but not the least, the device that's not that commonly used, however, it needs to be mentioned, is the tandem heart. Again, principle is quite similar to what an ECMO configuration is like, with similar bent cannula inside the RV. Essentially, it also uses centrifugal flow pump and 2 venous cannulas here to achieve right heart unloading. All said and done, I come back to the pressure volume loops again, and that's essentially to give you an idea of how these devices eventually impact on the actual physiology of the failing heart. So if you look at bypass systems such as the Impella or the tandem heart, you can very well see how much the use of Impella, when it's superimposed on a normal PV loop, adjusts itself. And you can, with the LV, it's more or less very close to the normal PV loop. However, with the RV, you can clearly see the big difference as to how the hemodynamics change. While in sharp contrast is how these devices fare in isolated RV dysfunction. And you can clearly see that the loop formed by ECMO compares very closely with the normal pressure volume loop of the RV. Again, based on this, you can come across, or you can come out with a lot of algorithms as to how you manage right ventricular dysfunction and how you initiate MCS devices in this cohort. There are controversies and challenges with the use of MCS devices. One of the important things that we debated, discussed, and eventually came up with this expert position statement was to how to diagnose RV injury, especially when mechanical cardiac support devices are on. In fact, we clearly figured out that there is no There is no diagnostic criteria which clearly defines it finitely. More importantly, we figured out that the terms RV dilatation, RV dysfunction, and RV failure are used interchangeably, and that's not right. So the diagnosis essentially should be multimodal, and you should be able to stratify RV dysfunction even in the presence of mechanical cardiac support devices, either with PV loops, where which probably is not possible in the immediate future in cardiac failure, but then there are devices coming up which can give you live PV loops so that you can assess the right ventricular and left ventricular PV loops as you manage heart failure. But the cornerstone of management would be based on echocardiography. Clearly, a lot of things we don't know. There are research priorities and open questions about right heart dysfunction and the use of MCS devices in this context. Clearly, this is an area that is still gray. So at the end of my talk, the take-home message, essentially, clearly, right heart failure has its own phenotypes. Clearly, it's a very difficult clinical entity to treat, sometimes refractory either, and even MCS devices can take long duration when it is offered. It's, however, safe and feasible. And last but not the least, a pragmatic approach to right heart dysfunction would be an early diagnosis or looking at prevention rather than getting absorbed into a vicious loop of this right heart dysfunction moving on to multi-organ failure. So a lot of onus should be placed on preventing it or diagnosing it early. Okay, I'll stop here, and thanks for the time as well as the opportunity to talk. Thank you.
Thank you very much. Dr. Ramanathan has vast experience in managing right heart failure. Right heart failure is still the big challenge. Today, he will bring us up to date on how we approach this challenging condition in the current area. Red wide have emerged as a crucial therapeutic option. Many thanks, Dr. Ramanathan, for your excellent presentation. This is my honor to introduce next moderator, Professor Jiang Chao from the Beijing Anzhen Hospital, Capital Medical University. Please, Professor Jiang Chao.
Okay, thank you, Professor Liu. I'm Dr. Jiang from Beijing Anzhen Hospital. It's now my great pleasure to introduce our next speaker, Professor Zhang Hang from Nanjing First Hospital, China. Professor Zhang is a core member of the team that pioneered the PADM procedure. Her extensive clinical research was pivotal in establishing its recommendation in pulmonary hypertension guidelines. Today, she will give us a speech about PADM in patients with pulmonary hypertension and heart failure. Please join me in welcome Professor Zhang Hang.
Okay, thank you. Thank you, Dr. Jiang. And good evening, distinguished chairman, colleagues, and friends. It's my honor to be here. And today I'm pleased to present my topic about pulmonary artery denervation in patients with pulmonary hypertension and heart failure. And in this presentation, I will focus on mainly on pulmonary hypertension and associated with the left heart failure, especially CP-CPH. And I will discuss the clinical need and the mechanism of pulmonary artery denervation and our clinical evidence in this patient population. So firstly, I will briefly review the current management of group 2 pulmonary hypertension. As Dr. Gao told us just now, heart failure is a complex clinical syndrome resulting from structure and functional heart disease. And now the management is built on guideline-directed medical therapy, including ACEI, ARB, or ARNI, or beta block, or MRAs, SGLT2 inhibitors, and other diuretics or others. However, many patients with heart failure do not only have left side cardiac dysfunction, but also they developed pulmonary pressures and increased right heart afterload. So this link between heart failure, pulmonary hypertension, and right ventricle dysfunction is the key background for today's discussion. Pulmonary hypertension associated with left heart disease is classified as group 2, and it is very common. Hemodynamically, PH secondary to left heart disease is defined by the mean pulmonary artery pressure above 20 millimeters mercury and a wedge above 50 millimeters mercury. So IPCH is defined by a PVR over 2 watt units, and the IPC is defined as a PVR lower than 2 watt units, and CPCPH is defined by a PVR above 2 watt units. So CPCPH is particularly important because it indicates that the pulmonary vascular resistance is elevated, suggesting the pulmonary vascular remodeling and increased right heart afterload. So according to the data, it is also highly common among patients with HFrEF. About 62 to 73% they may have pulmonary hypertension, and in HFpEF they may have 46 to 83%. It's very high. So and pulmonary pressure is closely related to prognosis. Every 5 millimeter increase in the mean pulmonary pressure is associated with about a 9 to 10% high mortality risk. So let's look at the treatment. Although the multi targeted therapy for group 1 PAH, these drugs are not very recommended for left heart disease secondary to pulmonary hypertension. So these trials list here tells us this kind of disease cannot simply be treated by transfer from PAH drug strategies. So we need new therapies involving the left heart pulmonary vascular right ventricle afterload and the neurohumoral regulations. So our one important mechanism is the overactivity of the sympathetic nervous system. So patients with pulmonary hypertension may have increased heart rate and other sympathetic nerve activities. So, however, systemic sympathetic beta blocks or others can be challenging in this kind of patients because some patients relies on the high rate to maintain cardiac output. So our target strategy is local modulation of the sympathetic nerves around the pulmonary artery with the goal of reducing pulmonary vascular resistance and right ventricle afterload without causing broad systemic hemodynamic instability. So this is our mechanism background for PADing. And this slide shows us the sympathetic nerves are distributed in the advantage of the pulmonary artery. And when the nerves are overactivated, the PVR increased and the right heart failure increased too. So the key point is that it's a self-reinforcing cycle. So our pulmonary denervation is designed to interrupt this destroy cycle by moderate the local sympathetic signal around the pulmonary artery. So let's move to the next part about the current situation of pulmonary artery denervation. Pulmonary artery denervation is designed by our Professor Shaoliang Chen, and it's a catheter-based innovation that targets the sympathetic nerves around the main pulmonary artery and the pulmonary artery bifurcation. Its goal is not simply vasodilation, but also we aim to influence the pulmonary vesicles constriction, pulmonary vascular remodeling, and the right ventricle afterward through the neuromodulation. So pulmonary artery denervation studies proved that we can decrease the mean pulmonary artery pressure, decrease the PVR, and increase the cardiac output. And also we can increase the 6-minute walk distance and decrease the clinical worsening events. So this slide showed us the development of the pulmonary artery denervation evidence over more than 1 decade. Early, our animal studies shows that the pulmonary artery denervation could reduce the hemodynamics and attenuate the pulmonary vascular remodeling. And then our clinical trials, including PADing-1, PADing-5, and the PADing-CFDA trials, they are the multi-center randomized trial and sham-controlled. From these slides, we can get 2 key messages here. First is that evidence have developed from mechanism study to the feasible studies and to the randomized control studies. And we have the long-term follow-up studies. Second, our study population has expanded from the group 1 PAH to include group 2 PH, especially CPC-PH. So as the evidence shown, PADing has also gained the increased attention in guidelines and other expert statements. So including in the Chinese pulmonary hypertension guidelines, and also is included in the 2022 ESCRS pulmonary hypertension guideline, and also the 2024 Chinese expert advisory for PADing, and our other Chinese Right Heart Failure Expert Consensus and Chinese Acute CHD-PAH guideline. And also from the downshirt, we can see the PubMed search trend also showed an increase in PADN related publication, and it shows the research activity and broader academic interest about it. So PADN has also made important progress. We can see it received the NMPA approval in China in 2023 and the CE approval in 2025, mainly for the Group 1 PAH indications. This means PADN is can use the clinical use in selected indications for Group 1 PAH. And also, we can see from this the worldwide application of PADN in China, more than 1,000 clinical applications have been completed, including commercial use in PAH and some clinical studies in Group 2 PH. And also in Europe, Southeast Asia, and Middle Eastern, PADN has obtained approval for PAH. Overall, PADN has involved for China original technology into a therapy. So in some other countries. So next, let's move to the third, but the most important part of my topic, the clinical benefits of PADN in patients with CPC-PH. To date, this slide shows us PADN has accumulated more than 10 years of research experience. And as I said, the clinical evidence mainly covered from Group 1 PAH and Group 2 CPC-PH. For the CPC-PH, the key question is whether PADN can provide additional benefit on the top of the GDMT heart failure therapy by reducing the hemodynamic parameters, and could it improve clinical outcomes? So we finished some PADN studies in Group 2 PH, and also we are ongoing some clinical trial for Group 2 PH. From this chart, we can see PADN-5 was a prospective multi-center randomized sham control study in China with 98 patients, and it has been completed, and it proved that the CPCH could benefit from PADN. And also the second clinical trial, PADN HF-PF, was another RCT trial, and it has been completed too. We are waiting for the publication for this trial. And the third PADN Columbia trial was a prospective multi-center single-arm open-label international study. Only we have 30 patients in it. I will introduce it later. And also we have the fourth clinical trial called PADN IDE. This is a very important trial. Is a larger prospective RCT in the USA, Europe, and Asia with planned 410 patients. It has received IDE approval, and it is enrolling now. So together, these studies showed the PADN in group 2 PH has moved from the exploring work to more clinical evidence. So next, I will focus on the two studies of the CPC-PH. Firstly is the PADN5 trial. This was a multi-center RCT trial, and we have the longitudinal study to assess PADN in CPC-PH patients. Totally, a totally of 98 patients was enrolled, and the inclusive criteria includes the mean pulmonary pressure high than 25 millimeters, and the PVR above 3 watt units, because it was designed in before 2018, so we used the old standards. The patients was assigned to two groups, the PADN group and the control group. And the study showed that the primary outcome is the 6-minute walk distance. We can see at the baseline, the two groups was similar. After treatment, the PADN group showed sustained improvement in exercise capacity. And at the 6 months, 6-minute walk distance increased by about 80 meters in the PADN group, corresponding to 21.4% improvement. And also we can see the difference was significantly with a p-value below 0.0001. And importantly, the improvement persisted at 3 years. We can see the right column. The PADN group maintains improvement of about 80 meters, while the control group improved only about 8 meters with a significant p-value of 0.003. So this suggests the PADN produced a meaningful and durable improvement in exercise capacity. And also, we can see the hemodynamic and biomarkers changes. At the 6 months, PVR decreased by 34.5% in the PADN group, and the cardiac output increased by 18.4% in the PADN group. And the PAWP, the wedge, decreased by 27.5% in the PADN group. So we can see in the right, in the PADN group, NT-proBNP decreased by 47.5% at 6 months, and by nearly about 40% at 3 years. So these findings suggest that PADN improved not only symptoms and 6-minute walk distance, but also pulmonary vascular hemodynamics. And also we let's focus on the clinical worsening. After 1 year, cardiopulmonary death occurs in only 4% of patients in the PADN group, and we have 18% in the control group, and the rehospitalization only occurs in 19% in PADN group, and 40% 2% in control group. So, and we can see the event-free survival curve also favored PADN. And at 6 years, PADN continued to show lower event rates. Cardiopulmonary deaths was 19% versus 32%. And other event-free survival was 62.5% in the PADN group and 38% in the control group. So we can see the benefit of PADN was not limited to the 6 months endpoints. It's also associated with a lower risk of clinical worsening. So let's move to another clinical trial. I said that's PADN global trial. This was just a pilot prospective only designed 30 patients from 7 sites in 5 countries. The inclusion criteria include mean pulmonary artery pressure higher than 20 millimeters mercury and a wedge above 15 millimeters mercury and a PVR above 2 word units. And also we can see we have the average age was about 68.8 years, and the male to female ratio was 50-50. Half-ref and half-pef was also at 50-50, and most patient was New York Heart Association Class 2 and to Class 3. The patients received PADN plus GDMT therapy, and the primary endpoint includes serious adverse events and change in 6-minute walk distance. And second endpoint include change in hemodynamics and New York Heart Associated class and KCCQ score. We can see at 6 months follow-up, both functional status and quality of the life improved. Firstly, 6-minute walk distance increased from 270 meters at baseline to 319 meters at 6 months. So we can see the significantly improvement of 35 meters, and the KCCQ score increased too. And we can see the New York Heart Associated class also improved. We have so many patients improved in class 1, and for the hospitalization, only we have 1 patient required rehospitalization in the 6 months after PADN. But before PADN, 10 patients has at least 1 time heart failure hospitalization. So it could be the change. We can see the benefit. So we can see the right heart catheterization data also showed improvement. At 6 months, we can see the improvement of mean pulmonary artery pressure, the wedge, and also the PVR. So we can see the hemodynamic tables, the detail of the patients, and So we can see pulmonary artery pressure and PVR improved while cardiac output was preserved. So let me summary my topic. First, the pulmonary hypertension secondary to left heart disease is the common form of pulmonary hypertension and is highly prevalent in patients with heart failure. And it is worsening prognosis even in CPCPH. And secondary PADN is a China organized international therapy designed to modulate sympathetic nerves around the pulmonary artery, and it could be benefit the hemodynamics and also the 6-minute walk distance. Also, currently, the PADN may prove 6-minute walk distance, hemodynamics, and others in PAH and CPCPH. We have some evidence of the clinical trial, but we need larger other designed and longer term studies to prove our benefit, long-term clinical benefits for these patients. Okay, I will stop here and thank you for all your times.
Many thanks to Professor Zhang Hang. Over the past decades, you and your team have systemically advanced the field of PADN from the initial proof of concept studies to the robust clinical trial. Your work has not only transformed the treatment landscape for pulmonary hypertension, but also has been recognized in the Chinese and international guidelines, a truly outstanding contribution. Thank you again, Professor Zhang.
Thank you.
I think we have overshot the time a little bit. So I think we should, all the moderators can have the one comment. Is a wonderful session, and then we'll close the session. So I request Professor Ying Liu to give her comments, and followed by Dr. Tigari, and we'll close the session. Dr. Ying Liu, Professor Ying Liu, your comments.
Oh, thank you so much. It's very helpful. Thank you so much. Excellent presentation. So this is the so many the newest knowledge. So I think it's very helpful to our practice, the clinic. So thank you so much.
Dr. Tigari.
Thank you so much. It was a really nice program and nice lectures. Thank you, AHS, for this invitation, and thank you all the speakers for a very good content on this difficult subject of cardiovascular disease, that is pulmonary artery hypertension, especially for the country like Nepal. The problem is that availability of these drugs and newer technology is not that good. So we have to still rely on those basic treatment options, but hope that within few years we will have that those drugs available in the country, or newer therapy will be available in the country. Thank you very much.
Thank you very much. I think we'll close the session. All the speakers, wonderful talks, a lot of information. I am sure that the audience would have gained a lot. Thank you very much.
Bye-bye.
Thank you.